Recording and transcription. Started by you. Let everyone know they're being included. Yes, we're all included. Okay, cool. Tamara's got her notebook. Anna's making coffee. Ivana, I told them when I did this content earlier today, from like 2 to 3, we went over by a few minutes because it's a lot squished in this little section. So if anybody has to jump off early, that's okay. At the very end, there's like 5, 6-ish little like trivia questions or whatnot, but I'm going to send out all of the slides for today in a PDF format, and I'll send them all out to you guys. Katie, I have your email, right, Katie? I want to make sure that I get them out to you too. Let's see, Katie Bailey. There you are. Yep. Okay. I wanted to make sure so I could send it since I've got both of you on here. All right, here we go. Let me move this screen over there so that I'm actually looking at you guys. And then we're going to share the screen. I'm going to find my share screen button because I don't know what happened to it. There it is. It went away for a second. All right, here we go. All right, so today's content is going to be head and neck. And head and neck, you guys see my screen with a giraffe, right?
I'm gonna record it and she's gonna say the reply. Okay.
Yes, I see your giraffe.
Oh, there's Holly. I thought I let her in already. Holly keeps falling off. All right, there's my giraffe screen. So when Holly pops up, we'll let her in again. I don't know. She's there. I think that the system's glitching. That's really weird. So head and neck on TCRN is 33 out of that 150 questions. And so head and neck seems that chapter in like the book kind of covers like head, TBI, some spine stuff, and then like face and eyeball and neck. So it kind of pushes all those together. So if it seems a little overwhelming, we can revisit some of the content, but I tried to put it all in here as we went along. All right, mouse. My mouse doesn't want to work. Next. Okay, so let's start off with like a little challenge question. Now, when I first read this challenge question, I didn't know what the answer was, and I had to like learn about it myself. But during report, you learned that your patient is exhibiting ataxic breathing. What breathing pattern would you expect to see when you assess the patient? So what do you think ataxic breathing is? Is it deep, rapid respirations with a regular pattern, or is it like shallow and then deep with an unpredictable pattern? Do you have a prolonged inspiration and then a pause, or is it cyclic respirations that, you know, go down to apnea? What do you think?
Sharon is gonna record the meeting and she's gonna say.
I'm gonna mute her right there so that she could talk to them. I don't know what's going on with the thing. Okay, so what kind of respirations do you think that we would see if we were calling it ataxic?
I feel like maybe B would be my guess, but I don't know.
Good guess. That's a really good guess. Actually, that is the great answer. Let me see if I can click it down here. Go to the next slide. Yes, B. It's shallow and then deep respirations with an unpredictable pattern. I think of it like sloppy torsades. Okay, so torsades, if you think about it, you have like little, big, little, you know, it kind of has that weird axis. And so I think about that, but sloppy because it's not regulated like we would see that. So that's just in my brain. That's what I was thinking for ataxic breathing. And that is part of some respiratory issues. So you can see differences in your respiratory patterns based on where the issue is in the patient. And what's going on there. So the pattern of ataxic breathing reflects medullary damage, and it's usually kind of like one of those pre-terminal signs in patients that have a severe brain injury and damage. Now, what you'll see with some other brain injuries is things like, I'm sorry, not others, but with this particular one, it's often seen midbrain or upper pons. It'll be kind of like regular with those. And then you'll see prolonger. That's a really great word. Clearly, I didn't spell check that. Prolonged inspiratory effort and then an inefficient expiration. I think overall, globally, what we remember is that when we have abnormal respiratory patterns in a patient with a brain injury, that's kind of one of those things to look at. And we'll talk a little bit more about that. Okay, so let's do basic neuro assessment. Now, you guys are really good with your patients. You have ICU patients. I had some ER staff earlier today, but in the ICU, you guys are really on top of what's going on with your patients and how they're there. So we'll check a few different things to measure their level of consciousness and interaction, like their spheres of orientation. So in somebody with a brain injury, you have these 4 spheres of orientation, and they'll disappear kind of in this order. So if you think about it, if someone just has like a small amnesia event, maybe they were in like a car accident and they bumped their head and they have amnesia, but they still know what time it is, the place they're in, and who they are, then maybe they've just lost the event. Whereas someone who's got a bit more of a brain injury will kind of hop down this little train right here. Maybe they don't remember what happened. Maybe they don't know like their orientation to time or the month or the season, something like that. But maybe they can look around and identify, hey, I'm in a hospital, and hey, my name is Sarah. Okay. And so you'll see them kind of disappear in that order. And I feel like I remember having a question kind of like this. I had a question on my exam, and it's funny because I don't remember a lot of the questions, but when I did have one that had to do with something like this out of these, which patient's doing better or whatever, someone that knows the event or someone that knows where they are. And it really kind of shows how they can lose those pieces as they go along. We also look at their effect overall, just general. We know that some of our patients that have those brain injuries can have they can have like a really flat affect. They can have, they can be just kind of like really weird. Some of them have like the crazy eyes. Those are my favorite. And so we can look at that, and then just kind of their general intellectual functions. For motor and sensory, I know that like I am really bad to go in and just like talk to a patient and be like, hey, squeeze my hand. But that can be a reflex with people. So instead, if we're really trying to gauge, are they comprehending the command and can they execute the action? We have them do a task like stick out your tongue, because they have to understand the words, process the information, and then be able to do that action, which kind of shows you that those things are working. Or hold up 2 fingers. I know a lot of my team will go around when they say the patient and they'll be like, give me a thumbs up, right? So the patient has to be able to process that information. Whereas just like squeezing, if you just put your hand in somebody's, it can be very reflexive that they just do this motion. And so we don't really want to use that. Now, it's different if we're assessing grip strength, that's fine. But when we're assessing their motor and sensory function from an assessment standpoint of how their brain is processing, that's when we would want to use this instead. And then we look at their pupils. Their pupils can be different shapes. We want them to be round and regular and equal. But if they have like an oval shaped pupil, we start to be really concerned about something like a midbrain lesion or compression. And that oval shape happens when you start to get increased intracranial pressure and it hits on that cranial nerve, like number 3, that it can change the shape of the pupil, which is really bizarre to me that it can do that. The body's really weird. If you just have one side that's not working correctly or it's fixed, then we worry about those herniation things. And then we have this anisocoria, where you have a difference between your pupils, but that may be very normal for your patients. Sometimes that happens. You'll have someone that has like 2 different pupil sizes there. All right, in motor and sensory, we start to look at other things and how they're doing. I feel like a long time ago, we used to be like sternal rubbing all the patients, and I don't particularly like that anymore. I just feel like it looks really crude and rude. But I really like this little piece of skin that you have right inside your arm here. You can make like the world's smallest violin and kind of get a little piece of skin and kind of like roll it in there. You're not even pinching them, but it just like hits those little nerves. If you need to wake yourself up, you can try that. It's like getting a little piece of skin and just kind of, but it will elicit a response. Anyway, with that, patients may localize to it, withdraw. You may see some posturing if they're having some other issues in their brain. But what we don't want is to see a patient that's flaccid to any kind of response, right? Now, have you guys been updated on like the new brain death criteria that's come out? It's like, yeah, I sat through that presentation a couple of times just so I could get a good grasp on what was going on. And they have changed it, and I do think that that's fair, because we do need to make sure that we have like sedation, and any medication that could have a longer half-life needs to be like eliminated out of the system so that those patients have the best chance possible to really show and manifest what they may or may not be able to do. All right, moving on. All right, vital signs. So what happens to our vital signs when we have like a brain injury or something going on? So when we have increasing ICP in these patients with our blood pressure, we'll start to see some changes. So they can get hypertensive. We might see a widening pulse pressure, or they'll just kind of continue to go up and up and up like that. With their pulse, they will decrease. Now, I feel like the worst part of the pulse in a patient with a brain injury, if they're not having like pain or they're being stimulated or something like that, is when we start to see their blood pressure go up, and then their heart rate also starts to go up, and then that heart rate abruptly drops and they get bradycardic, because that's kind of like their little rally point, and then they crash. And that's usually when we start seeing those really awful signs that they're about to herniate with the amount of pressure that they have going on. So if we start seeing a decreasing pulse rate, bradycardia, but it's bounding still, or we see bradycardia with irregularities, we should be really concerned about those. Temperature regulations can be altered in these patients because that particular part of their brain may be having some effects from whatever's going on. I told the group earlier today the worst patient that I saw with temperature issues actually wasn't even a trauma patient. It was a little old lady who had a stroke, and the stroke affected her like thermoregulation in her brain. And she was like a DNR DNI and was like 118 years old. But essentially the family said, no, we're not going to really do a whole lot. Well, I mean, and there's not. What can you do, right? If your brain doesn't know how to regulate temperature, what can you do for that? And so they ended up just kind of making her comfort care, and her temperature just rose and rose and rose and rose until she just like passed away because her temperature just got really high. I've never seen that before, but her brain almost like kind of cooked her, and it was like that was really weird. The body does strange things. But you also know that when they have these bad brain injuries, they'll end up with temperature control issues, and you'll have them on like the Arctic sun trying to regulate everything. They're not febrile because they have like an infectious process. It's like a neurological sign that something is going on in there, some things that we just can't fix. And with the respiratory rate, I feel like most of our patients with these bad brain injuries, they're not breathing on their own. We're doing that for them. But if they are not vented, then we might see changes in that where they'll get really rapid and deep with their respirations. And then they'll start moving into slowing down. And we might see some irregularities and apneic spells that they're having. Excuse me. Here's some differences that we see. Chain stokes, we have those kind of gradually increasing in depth, and then they'll decrease in depth where they'll have periods of apnea. And this can be associated with lesions like deep in like the cerebral hemispheres on both sides, or the basal ganglia, or in the diencephalon. So it's kind of a little bit of everywhere. Chain stokes is what we also see in patients that have like DKA, because the body's trying to regulate what's going on. We also have, if we have issues in our midbrain, in that upper pons area, any pressures and lesions, we can start seeing this hyperventilation, which is just deep and rapid. Again, if these patients are on vents, we're not going to be able to see these, but it's more of those patients I feel like that are not vented that start having deteriorations. Apneustic, they start having prolonged inspiration, and then you'll start to see a pause that's in there. And this is associated with pressure and lesions that are in the pons area. I like this little rainbow brain right here. It'd be nice if it'd light up and show us where their problem was. And then here was our little opening question for that ataxic breathing there. And this is when we start seeing pressure in the medulla of the brain, the medulla oblongata. I don't know why I remember that word. So what about ICP? What's a normal ICP for our patients? Where do we want to see it if we're measuring it? Idea? Anybody got an idea?
Less
Anything
than
less?
20.
Yeah, less than 20. This text says less than 15. But 20, absolutely right. If by some weird freak chance we had like a pediatric patient, like a small kid, then we would want to look at something like 0 to 5, because that would be normal in them. We're not treating those in your ICU, but we do have this information because those patients may come into the ER. So normal for peds, 0 to 5. In adults, like 8 to 15 is considered okay. Like you said, less than 20 is good. An ICP of like more than 20 to 22 is starting to look borderline abnormal, and we should start saying, hey, is there something we can do so we're not getting secondary damage? Because if it goes too high, once you get up over like that 40 mark, you're looking at a surgical intervention, or something has to happen really fast, or that patient's going to herniate, and we can't fix that. Managing brain injuries. Da, da, da. Okay, so what's the difference in a primary injury and a secondary injury? Any ideas?
Any primary is in the moment of the trauma or the
Mhm.
stroke.
Yes.
And the secondary is the one that is coming because of many metabolic problems or swelling or anything like that.
Yeah. Which ones do we have a little bit of control over?
Secondary.
Yeah, absolutely secondary. We
Yeah.
can't help that grandma falls at home, right? We want to put her in bubble wrap, but we can't. But what we can look at is how to prevent those secondary injuries here. So exactly, primary is what happens in the beginning. Secondary has to do with all of these things. So blood pressure regulation issues, if we have low flow because of hypotension, we're not getting the electrolytes, the oxygen, all of the nutrients that the brain needs. Hypoxia is a big one. I'm like a big proponent of the trauma patient needs oxygen until proven otherwise, and then we can figure it out, later. If they're not ventilating well, again, oxygen issues. What happens if we hyperventilate our patient? What happens? Hi, Shabana. I'm sorry you had trouble getting in. We're just talking about secondary brain injuries right now. What happens to the blood vessels in the brain if I hyperventilate?
They can be not dilated.
Yeah, they vasoconstrict, right? What
That's
causes
the word
that
I was looking for.
It's okay. I know you just woke up. I knew where you were going there. What causes the vasoconstriction?
Blowing off too much
CO2.
CO2.
Exactly, blowing off too much CO2. Now, it used to be probably anybody that's been a nurse for a little while, like Yvonne, you've been around for a minute, Tamara, you probably might remember this, that if the patient started looking like they had ICP or they were getting iffy, we would hyperventilate them on purpose to try and lower that, but we don't do that anymore. That's
No
kind of
longer.
that's fallen out of favor. We don't do that anymore because the thought behind it was a good thought initially, right? Until we learned better. Is that the brain, your cranial vault only has space for the three things that live in it: the brain tissue, the blood, and the cerebrospinal fluid. If one of those starts to take up more real estate, then something has to give up a little real estate. And so in doing that, we thought if we could close down some of those blood vessels, that it would give a little more room for the brain to swell. But now we know that that's not a great idea. Ooh, Holly's going to try and get back in with us. Hi, Holly. We're going to try it again here. Sorry, you guys had some trouble getting in. Holly, you like popped off like 3 times. I don't know. I think that the system's having some glitches, but it's okay. You're here now. We've only been talking about primary injury, secondary brain injury. I told the girls when we started, this one's got like a lot of content in it, so we're trying to squish it in, but I also am recording it. This is the first time we're trying to record it, so I can send it back out to all of you guys. And I'll send you these slides after we're done today on a PDF so that you can see them. So we were talking about why we don't hyperventilate our patients with brain injury, because we don't want to vasoconstrict them and lose that blood flow. We want to control temperature, electrolytes. Anybody that's been around for a little bit knows that Dr. Nicholas is really, really a stickler on balancing electrolytes on these patients, because any of our trauma patients, if you can't get the cells to function properly with all the things that they need, then the body's not going to be able to respond the way that we want it to. Whoops, sorry, I messed up my screen. Let me fix that. There we go. All right. So we'll balance those and we'll work on anything that we need to get everything perfused. There we go. I was like, my slide did not advance. I think I went too far ahead. Good grief. How far ahead did I go? There we go. All right. So what are some processes behind that? These are things that we just talked about, things that we want to do. The one thing to remember is that when we have secondary brain injury, it can be caused by that disruption to the flow. And then you get like this cascade of events that can happen. So you can get either swelling, hematomas that'll cause extra bleeding. You can get cytokine release from that neuroinflammation. It's the body's way to release things. It's kind of their immune response, which can make more stress on it. Those little damaged neurons get really sad and they just start throwing out everything that they have. So you have this extra glutamate that'll accumulate in there, which causes calcium overload. And everything in like our body, the body is really, it's really amazing how it's made, because everything needs to stay in its lane, right? And when things get disrupted, then those lanes are broken, and then everything is just going haphazard wherever it wants. And that just kind of goes downhill and cascades, and the body doesn't like it at all. So when we have things like our blood-brain barrier that gets disrupted, that allows everything to kind of move back and forth. So toxins move back and forth. It doesn't stay in its lane. Our immune cells move back and forth. The fluid will shift around, and then we get worsening edema that can happen there. All right, pop quiz. Which of these two is the force that propels the oxygen up into the brain?
Map.
The map.
Map.
Yep. And then which is the one that can actually repel that from getting up into the skull?
ICP.
ICP.
Yeah, ICP, right. So we need our map to push. This is why when we have patients with injuries, we have specific things that we need for them in order to get that flow up in there. If we don't have flow, the brain doesn't have the nutrients that it needs. And then our ICP has to be managed there, okay? So how do we raise our map in order to get things perfused up into the brain?
Increase blood pressure.
Yeah, increase the blood pressure. How do we increase our blood pressure?
Pressors, boluses.
Volume.
The things I put on the screen, right? Yeah, absolutely. So fixing volume, adding pressors if we need to. And pressors, we try and be careful with because we want it to push up into the brain, but we also don't want to constrict down things too much, causing that extra pressure when we're doing it. So it's kind of like this little game. But our goal is to maintain a cerebral perfusion pressure above 70. And we remember that we get our CPP with our MAP minus our ICP. Now, I also know that we are not monitoring ICP on all of our patients, but the ones that we are able to monitor, that's what we should shoot for a goal of. What if my ICP is too high? Like emergently critically high. Let's say I have an EVD or have a bolt and my ICP is saying that it's like 38, but I'm laying perfectly still and I'm not agitated. It's just really, really high. How do we treat that with our patients? What's an immediate, easy treatment?
Turn the lights off and give them some fentanyl.
Head of the bed.
Yeah, all of those things, everything that you just said. So head of bed raised, medications if they need to, pain medications, sedation, all of those things are appropriate, raising the head of the bed. And then we can also give them a couple of things, mannitol versus hypertonic saline based on the patient and what's best for them. Uh-oh, we lost Holly again. Holly's got connection issues, or the system doesn't like her. We'll talk a touch more about the difference between the mannitol and the 3% in just a minute as we go through here. I also realized that on the bottom of this slide, that nice CAT scan is upside down. So I get it, that's upside down. It kind of bothers me, but it is what it is. All right, so let's look at some specific head injuries here. So we've got some skull fractures. I pulled this picture off Google because I thought it was cool. Anyway, that's like a smashed, depressed skull fracture right there. The ones that are really depressed, they need to lift those off because you can have a lot of issues that come from that. And we'll go through each of these just a touch more in the next slides. So we also have our cerebral contusions, our bruises that happen. We can have bleeds that can arise from the different layers that we have in our brain. We have our concussions, which is like a more of a mild brain injury. And then we have our diffuse axonal injuries, which I feel like we get like waves of. We'll either have a lot of DAI patients or we'll have like no DAI patients, and we kind of swing back and forth. And the challenge with those is that these concussions, they may take some time to get better. It could take weeks or months, but they eventually usually get better. But with our DAI patients, if they're more moderate or severe, that lags around for a long time, and those patients may not actually recover function. There's a lot of things that we can do in the body to fix things. But when we have these little neurons right here that snap in the middle, they just don't grow back. And the patients that do have the better chance, I feel like, are the ones that are younger because their brain has so much more plasticity and the ability to kind of recover itself. But like if that happened to me, I'd be a potato, like laying in the bed, right? And I want you to cut my cords because I don't want to be a potato in the bed. But that's the challenge with those axonal injuries. Oh, it beeped at me again. Admit. Again, Holly, we keep losing you. I don't know why. It's not personal, I promise. All right, so let's look at some skull fractures. Is this a problem on my patient right here in the top corner? That smashed spot on their head. Do you think that's more than just a bone crack right there?
Yes.
Yeah, it looks like that's going down in, right? So we're going to have some breach of those barriers in there. We're going to have like bleeding. You've got tissue that's probably involved with that. You've got fluids that are moving all around just willy-nilly where it wants to go. So yeah, those dispressed fractures like that are going to have some kind of an intervention. The temporal bone on our head is the weakest spot. It's the most vulnerable to having injuries, and you associate that with epidural bleeding. With some skull fractures, depending on where the fracture is, there's a lot of vasculature that runs around in our head. And with that, you can have more bleeding just from the fracture itself, even if it's not like depressed in, just kind of the location of it's at. If it is depressed, though, we do see the risk of an increased risk of seizure in those patients. Also, like you have a bigger chance of infection because, again, we've breached those barriers where everything's moving around where it shouldn't be. Linear fractures, like I said, just, if it's near a vessel, you'll have like some, the possibility of some bleeding. And then some more compound fractures can get a little more complicated. So what do we see on this little picture right here with these very exaggerated makeup eyes? What's that?
Nice.
Raccoon eyes.
Raccoon eyes.
Vacila.
Side note, I have a little raccoon that likes to eat cookies on my front porch, and I left him some little Valentine treats for today because last night he was standing up eating a cookie, and he has those cute little raccoon eyes just like that. Don't worry, I'm not petting him because he might have rabies or something. What if we see bruising like behind the ear here? What do we call that?
Vital signs.
Battle sign, I know, right? It's real basic. And what fracture pattern are those two signs associated with?
Basilar fracture.
Yeah, basal,
fracture.
yeah, basilar skull race,
Basilar.
right? Yeah, it's the
Basilar.
skull-based fractures. Yeah. Are those patients at risk for having a CSF leak?
Yes.
Yeah,
Yes.
absolutely, right. And if you have a CSF leak, you also have a place where infection can enter too. So they're also at risk for infection. Now, this friend over here on the bottom right, do you think he has some fractures going on? Not just on his face, because definitely his whole face is broke. But do you think with this amount of energy that he's probably got some skull fractures going on in there? He did. He did. He had some basilar fractures. This guy was riding a motorcycle and he hit a box trucks with his face. So he was one of our patients a while back, but he has some really, really great fractures for like showing on there. And so I saved his picture on purpose because it was really good. So here's our basilar skull fracture. Here is a picture that shows the bruising pattern as it shows up. So a little bit of time after injury, you can see the different coloration that's in this bruising here. So when the patient first presents, you might not see a whole lot, but then within some time, you're going to start seeing it develop there as well. And then our little drawing guy, you see the areas where it can leak down because it is right there, kind of the skull base, like the base in there. And as it goes through, we may see, CSF leaking through the nose. It says that the patient may actually have like a salty or sweet taste because there is that amount of glucose that's in the CSF. Just the thought of tasting CSF sounds really like kind of nasty to me. But yeah, the big thing is we don't want to pack like the nose and ears if we see a leak. I have seen people take like a 4x4 and fold it in half and kind of tape it like a little mustache or something just to catch it as it's coming, but we don't want to pack things in those holes if it is leaking out of there. Some focal brain injuries. This is what I feel like we see a lot more common in our trauma patients. It's more localized into the area. So some cerebral contusions, hematomas, epidural, subdural, and then subarachnoid. And we'll kind of look at each of those. So focal, more focal area, cerebral contusions. We just get like that little surface area. It's like a bruise, right? So people that fall down and their head kind of bounces, or maybe they were in a car accident and their head kind of hit the side window. It's not a severe injury, but they've got a bruise there. They've got some changes and stuff going on. We'll see those. And then those are kind of on the surface of the brain. If it's down farther in it, we'll see more intracerebral hematomas, like down in the brain tissue itself and the parenchyma that's there. The big thing is treating the symptoms that we see. So the bigger bleeds, which we're probably more familiar with, are epidural bleeds. Is that, anybody remember, is epidural venous or arterial?
Arterial?
Arterial.
Yeah,
Arterial.
it is. It is. It is. Classic epidural signs. The patient will like have an injury, they'll hit their head, they'll have an immediate loss of consciousness. And then The patient will regain consciousness and be like, oh, I think I feel okay. But then within a fairly short time frame, I feel like within a few hours, they will just have this rapid neuro decline and they'll be completely obtunded. It's very, very textbook as to what that happens with people with epidural bleeds as they progress. And if they don't have surgical intervention pretty quickly, then they are going to proceed on and have a really, really, really poor outcome from that, from those epidural bleeds. Subdural. And nobody has seen a subdural in any of our trauma patients, have you? We never take
No.
care of subdurals, right? No. Every
Right.
person over age 65 that's on Plavix falls in their house and hits their head. And then they get a subdural, right? So our subdural bleeds, I've got some pictures of each of these in the next slides coming up. Our subdurals can be acute or they can be chronic. So as we age, our brain will atrophy down. And as it atrophies down, we do get a little extra space in there, which is somewhat protective for us because if we do fall on our blood thinners and hit our head, we're going to get a little bleeding there. But having that extra space can kind of save us, if you will, the joys of aging or whatever. Whereas grandma who's 95 years old has like a 5 millimeter subdural and she's talking to us, but if like maybe Anna, because you're young, your brain is not shrunk. If you had like a 5 millimeter subdural or something, you may be like, oh my gosh, I'm just really awfully sick right now and I don't feel well and my head hurts and I'm dizzy and I'm just whatever. Okay. So there is a difference, and it's because that brain does atrophy over time and they get a little bit of extra space. The joys to look forward to, right? What is subarachnoid? Where is that at? It's like down in. The way I remember subarachnoid is like arachnophobia. What is arachnophobia? It's the fear of spiders, right? I think it's the fear of spiders or bugs. And where do spiders like to hide? Down in little cracks and crevices, like in the back of your closet where things are locked. So think about your brain. It's got like those little cracks and crevices down in the sulci. That's where you see subarachnoid bleeding. It's down in those spaces. So I always think of those like little spiders, and I'll show you a picture of little cracks there. If it is a non-trauma patient, what you'll find is they'll come in and they'll complain of like this, like the worst headache of their entire life. They'll have really, really, really high blood pressure. And if it is a non-trauma patient, you'll find that it's probably going to be something from like an uncontrolled hypertension. They get these brain bleeds. We have to get their blood pressure down. If it is a trauma patient, we still want to get their blood pressure down to an appropriate level, but we also have to be careful because we want to make sure that we're still keeping their cerebral perfusion up. So it's a little bit of a balance right there. There we go. Here's some pictures. I pulled this off the Google, so I don't like the order of it, but that's okay. It wasn't my picture and I stole it. So intraparenchymal, down in the tissue right here. So you can see this bright white spot. It's down in the tissue itself. It's like a nice little focalized lesion. Those can be arterial or venous. Typically, you'll see them kind of round like that. Sometimes tumors show up like that, so they might need to do a little bit more imaging just to verify. But if it's a trauma patient, we pretty much are going to say, hey, that's what it's from there. Okay, this is going to have an acute presentation. They'll have like a sudden onset, from whatever their injury was. They'll have headache, nausea, vomiting, and stuff like that. Our intraventricular, so our ventricles look like this happy little butterfly here, and the white coloring in there you can see is the bleeding. So I feel like we see this a little bit more with our trauma patients. It can be arterial or venous, and really depending on the amount of blood and the presentation of the patient depends on if they have to do very much with it. It's going to kind of conform to and stay in the ventricular shape there. Now, notice right here, you can see like the little midline, that little webbing that goes down the middle of the ventricles. I saw a patient one time that it actually looked like a legit butterfly because it looked like a caterpillar worm. There were two membranes that had like a bimembrane ventricle, and I had to look it up because I was like, what's wrong with that patient? But that's like a normal variant. So if you ever see a really weird one that actually has like a little worm in the middle, it's not a worm. Hopefully, if it is, I want to see it. That's cool. But just like that little membrane, they have two of them, which is cool. So anyway, intraventricular blood right here. Again, headache, nausea, vomiting. The brain doesn't like having blood on it. It gets really aggravated. Now our subarachnoid, this is our spiders, right? They hide down in, you'll see them linear. See this line, the white line right there? that's where they go down into those cracks and crevices. Sometimes if you have a couple, it almost looks like a couple of little legs sticking out, but it's because it goes right down in those areas there. And this is like caused usually from like a rupture of like a weak spot. So if it is a non-trauma patient, this is usually where we see those aneurysms that have ruptured, or an AVM, those arterial venous malformations. They're predominantly arterial in nature, and it will kind of track along those fissures there. These are those worst headache of their life. This is why when they come in the ER and they're like, I've never had a headache this bad, they're like getting CAT scanned. I feel like we're pretty generous with CAT scanning people. All right, look, our favorite. We've never seen this in our whole life, these subdurals. So right down through here, kind of follows along the edge. What do I call it if it goes on the entire length of one side of the head? Fancy word. Anybody know? I know you know it, you just can't remember it. Holohemispheric. So if it goes on a whole side, you're going to see bleeding. This one is not holo, it's like partial right there. But I have a picture of one that's really big and it comes all the way down one side. It doesn't have to be on one side. Some of our patients will end up with bilateral subdurals. They'll have bleeding on both sides of the brain. Those are going to be venous. It's those bridging veins between the dura and the brain. And remember, as our little old brains shrink, they get smaller. So then those vessels get kind of stretched. They get a little more tension on them. And when they fall, they kind of snap. And so that's what will cause that bleeding there. Plus, it's their plavix. That doesn't help at all. And then lastly, our epidurals. These are going to be very classic right here with this, they call it Lenten form. I think of it like a half circle, a crescent shape that's going to be in there like this. This one has swelling on the outside as well. And so right here, you're going to see this. This is a smaller one. I've seen some that are like really, really big. And when they get bigger, you see a midline shift. So all of the midline's going to push over to the one side. That ventricle is probably going to be really flat. You can see it's already kind of smushed right there. These are going to be surgical emergencies because without it, the patient's going to die. They have to relieve that pressure. All right, so what about our other less traumatic, but not as, I mean, they're still awful injuries that aren't quite big bleeds there. So our concussions, those can last just a couple weeks to maybe some months after injury. And really, there's not a lot we can do. We can put these people on brain rest, where we basically take away all their electronics and tell them they can't read. They can just kind of lay there and look out into the abyss, right? And you want things to improve. Like there's not a whole lot. We can, treat the nausea, treat some of the pain and stuff. We have to be careful. We do have the Concussion Institute that we'll send patients to, but this is a time thing. We just have to give them time. Now, when we have our axonal injuries, remember we've snapped those neurons. And when we snap them, they're not going to just grow back. So with those, for a moderate axonal injury, they're going to be comatose for like the first 6 hours post-injury. And the thing is, sometimes we'll get that initial CT and the CT will not actually match the patient presentation because the patient's going to be like obtunded and they're just going to be comatose. But then you do the CT expecting to see like some big bleed or some big problem, but there's not really anything there. And so these are the ones where we're like, I don't know, it's have to wait and see kind of, and then we repeat their scan a little bit later, or we get an MRI. And when we do that, we see these little punctate lesions. So it looks like you took like a marker and you just went like pop, 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 pop on those CAT scans, just little tiny things. They're kind of hard to see. And that's where those little neurons have snapped. Okay, so these patients will be irritable and agitated, really impulsive. These are the ones that are hard because we know that they have a brain injury, but they're trying to crawl out of the bed. But at the same time, we don't want to snow them and sedate them. So it's like this really bad balancing act that we don't have a lot of great options for. Like once they get off of like IV drips and they're just like impulsive, we can put them in a veil bed or something. But in that initial state, they're kind of like lost in their head. They don't really know what's going on. Have any of you guys like ever woken up after being asleep for a really long time or even a short time? I think mostly when you're sleep deprived and you wake up, but you're kind of not all the way awake. You're like halfway between asleep and awake. and you're not really sure where you are or what's going on, and am I asleep? Am I awake? And you're in that kind of twilight zone. I feel like some of our patients, as they're emerging out of these things, that's kind of how they feel. So we're telling them, it's okay, you're okay, you're okay. And they're like, I don't know where that sound is coming from. I don't know what that voice is. Why is there something taped on my arm? What is this squeezing thing over here? And it's just really disorienting for them. And so with those patients, I usually like the first thing I like to tell them is, you're safe, or like there was an accident, you're at the hospital, you're safe. We're helping you, right? Just to kind of reorient what's going on. But even with those, sometimes it's really hard and you just repeat yourself all over. For the ones that are more severe, though, these people are going to be comatose that's going to last a long time. They're going to remain in those persistent type vegetative states. And if they do emerge from those coma states, they're not going to have very much function at all. They're going to be like total care type patients. Those are really sad because they may have legit been minding their own business and just kind of like doing whatever it is they do, and then there's some accident that happens and they get this really bad injury, and you're just like, we can't fix it because there's nothing that we can put back together there. And so those are the hard ones. We had several of those. All right, so let's peek back at our ICPs here and talk about some medications for those. So ICPs, we talked about that, our normal states there. Once they start getting really, really, really high, we start seeing progression down this phase where they're going to get confused, they'll get disoriented, they'll start to combative, they'll get lethargic, and then they'll get obtunded, right? You could see some motor sensory deficits from that, kind of some, droop or whatever. They're going to have vomiting, but they may not necessarily have nausea. They're just like vomiting because the brain gets really irritable. And when your brain is irritable, anybody had like a bad migraine or a bad headache and you get nausea with it and you're like, why am I nauseated? Because when the brain is just having a bad day, it says, let's throw up everywhere. You just get this overwhelming nausea. But with these type brain injuries, they don't have the nausea component. They're just like vomiting. If you have that severe ICP where it gets above 40, these patients are not likely to be awake. They're going to have a loss of consciousness. You're going to have significant deficits, and you'll start seeing posturing that happens. All right, so decorticate, show me what decorticate looks like with your hands. What's decorticate? Yeah, we're pulling into the core, right? And then our decerebrate, which is worsening, right? We're going out like that, exactly. So this is still protective of the body. And so decorticate is, if you had to rank them, better than decerebrate. Decerebrate shows significant derangement in your brain. Someone tell me what Cushing's triad is. What are the things that we see?
The symptom of
widening blood
herniation,
pressure.
Brady.
Yeah, yeah. And our symptoms for that are going to be
High blood pressure.
Yeah.
Brady,
Bradycardia.
respiratory
Yeah.
compromise, like irregular.
Yeah, exactly. And if they're not on a vent, we would see irregular respirations or slow respirations, but these patients probably at this point are like vented for airway protection at that point. All right, how do we monitor ICP? One second. Oh. All right, now we're monitoring the fact that it is way too hot in my room. So let's turn down the temperature. I'm getting hot. All right, so a couple of ways we can monitor that ICP. And I feel like we don't do a lot of this at all, but we just don't do a lot of it. So they can get an EVD. So this goes like down into the ventricle of the brain. It's that little nice drain that sits in there. The benefit of that is that you can drain out some cerebrospinal fluid if you need to pull off a little bit of pressure. So you get a pressure reading. You can kind of adjust the pressure if they need to by withdrawing some fluid. But you can have a little bit higher risk of things like hemorrhage or infection. That tubing can actually get clogged or blocked. They can treat it, but they can be a little bit more finicky for complications, if you will. Now, a bolt, on the other hand, is like screwing it in. Everybody's seen a bolt before go in. My new friends here, have you guys seen bolts before? Yeah. Okay. So with a bolt, it actually looks like a bolt they're screwing in the head, right? And I feel like a lot of the time it's in kind of the same spot. So if you take like the whole of your ear and your eye and you bring your fingers up together, where they meet is kind of where that bolt comes in. It looks like an antenna like sticking up off their head here. And with that, it's a little fiber optic thing, measures the pressure on the brain. And then with that, we can kind of see how the patient's doing. Now, the difference with the bolt and the EVD is the placement, right? So the bolt has a lower risk of the complications because it doesn't go quite down in there. But if you have a really high ICP, you can't pull off any of the fluid like you can with an EVD. Like if you have a lot of blood or things going on, you're just kind of like, well, the pressure's high, but we can't do a whole lot with it. So each of them has kind of like a little bit different approach to what they do. They still give us a number. We can do a little bit more with one versus the other. One has a little more risk of infection than the other, and it's just going to come down to what the neurosurgeon wants to do for those. Now, if we do have a higher ICP and we're like, hey, let's give some medications, right? What are we going to give? So I asked the group this morning, what do you guys use more of? Do you use more mannitol or hypertonic saline?
Hypertonic saline.
Yeah.
Hypertonic saline.
And with your hypertonic, is it 3% or is it 23?
Generally 3.
3%.
Yeah. So there are like some differences. I feel like when I worked pediatrics, we had a tendency to use the 23% more than 3, but I also tried to stay out of the ICU for peds because I didn't like it up there. But in the ER specifically, we would just give that a little bit and then send them up there and be like, go, go, go. So they're just a little bit different in how that they work, and kind of you can look at your patient to decide which one's a little better. Again, neurosurgery is making these decisions. But mannitol itself is going to be an osmotic diuretic, so it's going to pull the fluid out of the tissues and move it more into the bloodstream. But what that can cause is if you're adding fluid to the bloodstream, you can increase your volume of what's going around. So if you have patients that have like heart failure, they already have pulmonary edema, they have renal failure, if we introduce extra fluid into their circulating volume, that might cause them a little bit of some challenges, okay? Now on the flip side of that, if your patient's hypovolemic, low volume, and you give a mannitol and it's shifting that fluid into the circulating system, it can actually help because it increases the volume. So that's one of the things about mannitol, pulls it out of the tissues. The mannitol can kind of accumulate in your brain tissue over a little bit of time, so that's just one thing. For the hypertonic saline, though, it doesn't accumulate in your brain tissue, but it also doesn't have like a super diuretic effect. So if you have someone with a low volume, it's going to be a little bit better for that. Some negative effects because of the saline approach to that is that you can have some bleeding issues, like your coags can get a little bit prolonged, your potassium can drop, and then they can develop hyperchloremic acidosis. So both medications, we use them emergently, I feel like, for these patients, and then the surgeons will kind of decide which one's going to have the better risk versus benefit for that patient, and then kind of treat them accordingly for that. Do those patients need a Foley? Yeah, don't come at me with the Foley police. Don't come at me for the Foley police.
Yes.
The poor Foley police. It's all good.
The Foley police is about to ramp up. Unfortunately.
I was on the hospital-acquired infection meeting earlier today, and they were talking about everybody that developed like a hospital-acquired infection. So Coddies, Clabsies, and there was something else I don't remember, but they had to basically present everything that happened. And I was like, oh, wow, like some of these people, they just can't help it, right? Like, you know, it may just happen, you know, but I mean, I get it. We don't want patients to have like hospital-acquired infections, but also we got to monitor these folks' output. Okay. So that's a lot of brain squished in a short time frame. And I was looking at the time. Let's see, it's 8:53. I told them earlier today, this presentation went about 10 minutes over our time. So I'll keep talking. If you can't hang around, that's okay. We're going to record it, but I'll still send out all the slides as well. Otherwise, we're going to go through neck, a short bit of the spine, kind of the face, and some eyeball stuff. And it's just how this was mushed. I didn't realize how big it was going to get until after I built it. All right, so neck and our spinal cord. Our spinal cord has different sensations and does different functions based on where it is. I think of the spinal cord like one of those string cheese sticks. I should have brought one. I don't even know if I have one in my kitchen. The string cheese sticks where you pull down the little mozzarella cheese, like my kids like it. So that's kind of like your spinal cord, right? So if I twist it, I might have damage on one side, but not the other. Okay. Or if I kind of bend it, I might get some fibers that kind of fray out on one side, but not the other. And this is how we get patients with partial cord injuries. I feel like trauma runs a special on central cord injuries. So central cord, it's in that central part. And this is where these patients have that profound, like upper extremity weakness and just some gross motor movement, but their legs are fine, right? So with like a central cord, they can like walk into the grocery store, but you can't put anything into your buggy. Or I saw another thing that said you can dance, but you can't play the piano. So you just have that weakness. And we've had a lot of patients with that. With our little old friends, they like fall and hit their head on a table and they get this like hyperextension injury. And that's where they get their cord injuries. Others, like our friend that was in like 5 a few days ago, his was from like his poor choices in his car accident. So you know, hopefully he'll get some back because he's younger, but our older friends, they may not get that stuff back. So the different areas of our cord, as you can see here, they do different things. But if we were to take our cheese stick and cut it in half, we have severed that completely. Nothing's coming back. Like it's not, right? It's just not going to happen because those things are lost at that point. Oh, look, I just talked about that. They're central. Cauda equina, this is more down by the coccyx. If you break your tailbone and you get some cord injury down there, then we'll find that we have problems with our bowel and bladder, weakness in the legs, and we need to treat those appropriately if they need to be on like appropriate like bowel and bladder programs. Spinal shock is probably the best thing that you can get because this can be reversible. It's like having a concussion on your cord. It can last like a concussion for a couple of weeks, but usually it will kind of get better with those. Not all of them do, but some of them do. But in the beginning, it might be really awful for that patient. All right. What's the main priority in any patient with any problem? Main priority. Airway. Airway. Well, bleeding trumps all, and then airway, right? Can't let them bleed to death, but then airway. But above that, once we get there, then we treat based on the injury. So I feel like you guys have a lot of really good neuro patients that come through there where we see a lot of these cases here. So if we have those C-spine injuries and it's a cord injury, what level do I want to have a C-spine injury on if I have to have one? What would be the most preferable?
7.
Like the lowest possible.
Yeah.
The
So that I
lowest
can
one.
breathe, so that I can breathe mostly on my own, right? If I have a cord injury at C3, can I breathe on my own?
No.
No. C5 is usually the level that keeps us alive. So C5 keeps us alive. This is more the level where we'll still have the ability to do some of that. Now, remember, just because I have a C5 injury doesn't mean I can always breathe okay on my own because you know our patients, they get those injuries in the cord and then they get edema. And with that edema, it can like go up in the cord. So they can actually have manifestation of a higher cord injury based on the swelling that's happening. So if you end up with like a C5 injury that acts like a C4, then you might lose your diaphragm ability to help with breathing on that. So these patients can decompensate and start getting respiratory failure with that. It's just kind of rough. If you get farther down in the spine, like above T7, those patients are breathing really good, but they may not have a really great cough reserve or be able to take a good deep breath, and they might have troubles with secretions in there. And then T12, kind of, we start to lose our abdominal muscles. You might have some minor issues with coughing and that forceful expiration. I feel like some of the biggest challenges we face with our cord injury patients, they have a lot to deal with, but their respiratory status can kind of make or break how well they do based on what happens kind of with their sequelae of their course. All right. So how do we treat our cord injuries, right? Pressors. We put them on MAP goals usually for like how many days?
5.
Like about 5 days, right? So they'll hang out in the ICU with you guys for about 5 days. Now, if we see that they're making their MAP goals really well and we titrate them down, then that's good. We don't have to have them on pressors for a whole 5 days. We just want to make sure that they're making those MAP goals. We want to help them regulate their temperature. We've got to have a bowel and bladder plan in place because have you ever seen an autonomic dysreflexia on a patient? You ever seen that happen before? So autonomic dysreflexia, the body kind of gets confused as to what's going on. It can't feel anything below that injury, but if your bladder is really, really full, then the body can start having a mini panic attack and you don't know why. So your patient's going to appear distressed. They're going to have like diaphoresis. They'll get tachycardic. Their blood pressure may go up. And really, when you see it, you're like, I don't know what's going on with you. Are you in pain? Do you need an Ativan? Like, I don't know. But what's happening is the body's just responding to a stimulus it doesn't like. So that bladder's full, right? If we drain the bladder, those symptoms will go away. They won't be tachycardic, their blood pressure will come down, they're not going to be diaphoretic. So if you have a cord injury and they start acting really panicked, but they're not emotionally panicked, I guess you could say, but their vital side look panic and they're diaphoretic, look for something that's causing a problem, a full bladder, clothing that's too tight on the body. Maybe they just need to be repositioned, and that can kind of help reset that dysreflexic issue that you're having with the patients. There's some medications that I feel like they can give them as well, but oftentimes it's treating the cause in order to fix that. All right, neck, non-spine neck issues, right? So we have 3 zones in our neck. As you can see on the picture, this is where they're located. Depending on where the injury is, can affect different structures of the neck. So I feel like we have patients that come in that'll end up with like the seatbelt that's kind of creeped up by their neck, and then they're in some kind of an accident and they'll have like a seatbelt mark right there. And a lot of those we'll see, we'll image to make sure that they don't have vertebral artery issues in that area just from that. And if we do, it's probably going to be like a thrombosis or a little flap tear, and they'll treat that accordingly for it. Different ones, depending on how high it is, we can run into other injuries, like airway issues right here in the neck with the structures. If you get really up high on like the angle of the mandible, you can have some other things. And I've got some slides on each one of those. So is this a problem for this guy? I don't know how it got there. I found that picture on the internet and I thought it was great. What kind of structures are affected by that stick through his neck?
His airway and his spinal cord.
Do you think he'd be a great patient to try and intubate?
Yes.
Not orally, yeah.
What's anesthesia going to say if we
Right.
call them and say, hey, can you come take a
Crike
look
him.
at this? Exactly. He's going to get cracked real fast, because he has this large foreign object going through some really important structures. This picture kind of intrigues me because he doesn't seem to have quite as much bleeding as I would expect, or swelling for that matter. But regardless, this is a problem. So some things that we might see, if he were to transect his trachea, we would see things like some subacute air that may travel in there. You may see some bubbling. Were any of you guys around when we had the young lady that went through the windshield and had the big, like, half decapitation of her neck? She came
Yes.
in with a lot of structural issues. Yeah, and I mean, she had a really great outcome where everything got put back together and she healed up well. But that was like a pretty big neck injury across several zones. It got like her trachea. She had some vasculature stuff that was involved with that. Unfortunately for her, it wasn't any big vessels there. But you can have bleeding, big vessels. We can have esophageal injuries as well. Also, where's our thyroid sit? Kind of like right there, right? So if you have an injury there, or even this dude with a stick, this one's a little higher than his thyroid, but you might develop some issues from that as well. Now, not manifested in this picture, but also to remember in the neck, when we think about the zones, if it's down in this lower area right here, the patient may have like profound weakness in that arm from a brachial plexus injury. Sometimes we don't realize that until they've been in the hospital for a couple of days, because the first few days in the hospital, they may have been intubated or something and they can't move things and we don't know that they're having a problem. So sometimes we'll find this just a little bit later on. All right, eyeballs. Anybody like eyeballs? Anybody? Eyeballs kind of gross me out. So I had to find a gross picture to show you for that one. All right. All right. Oh, did I say eyeballs? Oh, face and eye. Okay, I was like, what happened? Fractures. So we'll look at some face fractures and then we'll talk about eyes. So different areas that we can have fractures on the face. Mandibular fractures. I feel like we see a lot of these in our hospitals. Not in our hospitals, in our ICUs. Sorry. Some of the things that we'll find is they can't properly open and close their teeth together, because when you have a fracture, it displaces things over. They may complain of numbness or like paresthesias to those areas. If you think about where your trigeminal nerve comes down, it kind of branches across your face. And if you hit some of those areas, or the like collateral nerves that come off, it's like when you go to the dentist and they numb you up, you can't feel anything. So they may say my upper lip is like numb or something. They may have drooling, challenges with swallowing. or we might find that they have blood in their eardrum or kind of running out of their ear. And that's because if you have these higher injuries that are up higher, think of it, feel up there and then open and close your mouth like this. You can feel it. It's really close up by that. And so that could cause some problems because it fractures in that area and you may have some bleeding that comes out of your ear and stuff. Oh, somebody's singing me a song. Who's singing? Is that Shabana? Is that your people singing? That was nice.
Yes, in the background. I'm sorry, I'm muting it.
It's fine. It's fine. Lefort fractures. I like these. I think they're cool. So Lefort is a classification of fractures in our face. And you can have a combination of like a couple of them. So I've seen patients that would have like a Lefort 1 on one side, but a Lefort 2 on the other. So maybe on the left, it only came across the upper maxillary region, but then on the right, it kind of came up into the orbital floor and across the nasal bridge. So you can have a combination of a couple of them, or you can have the ones. Lefort 3 is the worst, and 3 I remember being the worst because it looks like a bowling ball to me, so we would not do this. But if you were to take your 2 fingers and put them in the nose holes and your thumb in the mouth, like you hold a bowling ball, 3 things, Lefort 3, you could move the whole mid face. Now we're not doing that. Like that would be very bad. But in theory, that's what you could do. A Lefort 3 fracture, you have kind of disarticulated these bones and they're going to be sitting down. This patient may look like you have smushed their face. You know those little dogs that have the little smushed face? Looks like someone like stepped on their face. The patient might look kind of like that. Their nose may be kind of recessed. You'll see like bruising and swelling, but at the same time, everything is kind of down in. Now, are they going to present with an airway challenge? Yeah, because this is all mobile and everything bleeds in the face. So everything's going to go backwards and we got to get a control on that really quick so they don't aspirate. All right, what about orbital fractures? I feel like a lot of our little old friends get orbital fractures when they fall. They may or may not be displaced. If they're not displaced, then usually they just heal. If they are displaced, they may decide if they need to go in and intervene. But some things that would make you concerned that that fracture is displaced is if the eye does not move in sync with the other, because maybe the eye got trapped. So now this eye can't move because the nerves or the muscle, not the nerves, but the muscles rather, are trapped and it cannot move with the other. They may have some altered visual acuity, or you might see that that eye is like sinking down farther in, or I have seen the eye like come out and be out more where it's been pushed and there's pressure behind it. We don't want to poke it in if that happens. That just needs to be kind of covered with some nice little gauze and let ophtho fix that. Our cheekbone fractures, this is a really nice 3D reconstruction of a cheekbone fracture right here. We're going to find that these patients may have some of those ocular muscle entrapment as they get kind of stuck down into those areas of fracture right here. They're going to have trouble opening and closing their mouth like we did like that. This area is not going to articulate and roll on it like it should because it's fractured and sticking out. So that's going to be a problem as well. They may also have some numbness in there just because of the way the nerves are hit, and then their upper eyelid itself might not move correctly because of that nerve that's in that area may be impinged or damaged. What's going on with this guy? Any ideas?
He's bleeding.
Glove rupture.
Blah! This is a hyphema. It's blood in that anterior chamber of the eyeball. I don't know what happened to him, but that looks kind of gross. I've seen these before, and if they move their eyeball, that liquid will actually kind of like jiggle in like it'll move like a little wave in the eye until it kind of clots up, and it's kind of gross. Really, really important with people that have this issue like this is that we treat that pressure pretty quickly. And we're not giving them systemic medications for that, but they can develop a really high intraocular pressure when they have injuries like this, and that can lead to long-term problems. So there's specialty eye drops that they'll give them in order to decrease that pressure in the eye. The blood itself, we let ophtho decide what they need to do with that. I don't know that they're going to drain it or if they just wait, but it's just that just looks really gnarly. But we absolutely have to treat the pressure. The other thing that's really important with these patients, would we want to lay them flat in the bed or would we want to keep their head elevated?
Elevated.
Yeah, absolutely right. So just like we can decrease our intracranial pressure by raising our head up, we can also decrease the pressure in our eye by keeping our head raised. The other thing is we want our eyes to be resting. We don't want to be like looking around a whole lot, watching a lot of TV, because all of those movements are causing strain on that. You can put an eye shield over it to protect it, because if you have a lot of swelling, you may not be able to close those lids all the way, and you may want to protect that poor little eye. Should we give him aspirin? What about
Negative.
like their Plavix or something? Probably
No.
not. Probably gonna hold that, right? Yeah, because we don't want to make the bleeding get any worse. Now, I did not put a picture on here because it was a little bit too gnarly, but what happens if I tear my eyeball? What do we call that? A bad day? It's gonna be like a ruptured globe. So those, if you actually rupture the globe itself, you'll have that vitreous, that like gelatinousy fluid that's inside our eye will actually start coming out. And then the ophthalmologist needs to decide if that's something that they have to repair and kind of fix, or what their next steps are for that. If you do have a ruptured globe, you may see that the pupil has a really odd shape to it. It's not like the oval pupil from like an increased intracranial pressure, because it's not a pressure that's causing the problem. It's actually an injury in the iris itself. And so they may have like a weird shaped pupil, or it might look a little like defect the way that it's sitting in there. What's going on here? I think he decided that fishing was not his hobby anymore. So that's a fish hook in somebody's eye. That's a really big problem right there, because that's going in through, and it looks like it's actually going through the beautiful colored part of his iris and his eye. Do we want this patient to be looking around places? No, like that's, I'm not even joking about that. So with like the hyphema, where you have a lot of blood, you would kind of cover that one eye. If somebody has a foreign object in their eye, we're actually going to cover both eyes, because if I cover one eye, I'm still looking around with my good eye. What direction does my bad eye go as my good eye moves? It follows it, right? So if I have a foreign object, I need to cover both eyes so that I'm not looking around and having that movement, because we don't want that to move, right? So we're not going to manipulate it. We're not going to touch it. We're going to discourage that patient from doing things that might increase the pressure in their eye. So we'll again want them to kind of sit up a little higher. We don't want them to bend over, those things that would cause increased pressure. All right, review. Have y'all kept up? I know it's been a lot to kind of go through for today, but I've got like, I think like 6 little like questions, if you will. These are questions I pulled right out of like the summary review. So these are legit. These are kind of like what some of the TCRN questions look like. Okay. So our patient has an ICP, and it's measured at 46 millimeters of mercury 24 hours after their traumatic brain injury. How do we feel about that pressure? Is it normal?
Too high.
It's too high, right? Is this one just something that we're going to call kind of a moderate hypertension, or is this something that we want to do like an urgent intervention on because it's really high? I know, right? Yeah, actually, you're absolutely right. If the patient is presenting right, we know our equipment's not failing, the ICP is really high, then absolutely that's like a phone call of a, hey, you might want to come take a look at this kind of thing and get that patient taken care of. All right, out of these 4 categories here, which of these would be the highest level of functioning? So if all 4 of us were to be in one of these categories, who would be the best off?
Lethargic.
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 Exactly. So remember how earlier I said people lose their orientation aspects in, like, it goes through a little cycle there. They'll lose the event, and then, you know, like the time and the place and whatever the person. So in these levels of consciousness, lethargic, they're going to move in this direction. So they'll be lethargic, then obtunded, then stuporous, and then comatose. So if I had 2 patients and one was comatose and one was obtunded, the obtunded patient would actually be a little bit better off than my comatose patient when looking at the level of functioning. And I believe that I don't remember a lot of the TCRN questions that I had, but I did have a question that was something similar to this, where it gave me 4 types of patients and kind of the level of functioning, and I had to pick the one that was the best or the worst. I don't remember. So this was one of those that when I was reading it again this time, I said, oh, I remember that. All right, which of these pupil shapes is associated with an increase in the intracranial pressure?
Oval.
Yep, oval. Square, I feel like is an obvious that that's not the answer. Although I think it'd be really cool if you had a square pupil. I want to see that, right? I have seen a teardrop shaped pupil before. It's a congenital defect called a coloboma, and it's kind of an upside down shape of like a teardrop as well. I haven't seen a half moon, but you could see like a half moon or a crescent if there was trauma to the eye, but not square. We're not making square shapes. That'd be kind of neat. All right, which cluster of symptoms out of these categories is the most consistent with the subarachnoid hemorrhage? I'll let you look at those and tell me which one you think.
Severe headache.
Severe headache? The first one that's on there? Yep, exactly. Where is that subarachnoid at?
Deep in the brain.
Deep in
Yeah,
the
it's down
arachnoid
in those
spaces.
little crevices of
Right.
the sulci, down in there where our spiders hide, right? Subarachnoid, they're like little spiders. All right, our patient has a severe diffuse axonal injury, which would be common to see in the first few hours after injury.
Decline in level of
Right.
consciousness.
Yes.
They may. They may. Now, if it's a severe injury, they're probably already going to have that dropped in their level of consciousness. So in a severe injury, they're going to have persistent posturing. If it's like a mild or moderate DAI, then you'll see that decline in LOC and kind of some differences in their neurostatic. But if it's a severe one, they're going to be presenting with that posturing. Those are the ones when there's like a severe axonal injury. The patient doesn't match the CAT scan in that initial stage here. So the first few hours after injury, you're like, the CAT scan looks okay because that hasn't really manifested yet where we can see those snapped spots that are in there. So that's why they would be posturing. And you're like, I don't know why they're posturing. But that's it. It's the persistent posturing for that. All right. Which of these is reversible with time?
Spinal shock.
Renal shock.
Yeah, that's the one that's like the concussion. Like you get a concussion on your cord. So it may take some time, but they'll regain some function there, right? We're not going to improve on our axonal injuries a lot. And then with our cord injuries, they typically kind of just hang around for a long time. All right. If I have a patient with maxillofacial trauma, which would be kind of the highest priority of this patient? So my patient with a smashed face, what's going to be the priority?
Airway.
Airway.
Right. Always airway, unless they're hemorrhage, then you control bleeding. Otherwise, it's always airway. All of these are good, like controlling pain, that's really good. Reducing any ICP because you may have an injury with it, that's also good, but airway trumps all of those. Oh, yay, that was the last question. Woohoo! All right. So that was like a lot of information kind of squished in a little bit. And I know we went a little bit over on time and I apologize for that. There's just a lot of content there. Do you have questions about any of that?
No, that was
No.
really good.
If you
No,
think
thank
of
you.
questions that come up, I'm going to email out you guys the PDF version of the slides for tonight. I won't send them all at one time. I'll just send you the ones that we did tonight. If you think about a question, please reach out to me. I'll be wandering the floor the next couple of days, I think, because I think didn't they cancel your ICU staff meeting tomorrow? I was supposed to
Yes.
present at that, and then Landon told me it was canceled, and I was like, oh, okay, I didn't know that, so that's good. So I'll be wandering around the department the next few days, but regardless, it doesn't matter. Reach out to me if you guys come up with questions that you're like, oh, I don't know about this. If you haven't signed up for the My Northside Learning version of the modules that it goes through, they're quite a bit more in depth. And so you can do that. They're not super hard to find. You just have to log into My Northside Learning. Go to that little tab that says opportunities. Like if they ever tell you you have to self-enroll in like a learning module for something, you click that little search box and then just type in there the keyword like trauma. You'll get several different things. Just look for the one that says 2026 trauma certified registered nurse. You may see one that's from like last year. When I looked at it last week, they still had some populated from last year. Just pick the one that says 2026 because it's going to give you a lot broader content. But yeah, if you think of something later, you can just, send me a message or I'll be around. And next week, we're going to talk about trunk. So I like that one. It's like the chest, right? Like the trunk and problems that go on with that. But yeah, thanks for joining us. Sorry some of you guys had Holly, I know you had like an awful time getting in. I don't know what the issue was. I think that the system was glitching. When I figure out how
Yeah.
to find the recording, I'll email it out to you guys and then you can test it out and see if it works or whatever. Or if you just want to review it again, you can let me know. If it's up to you. But
So
otherwise,
about those modules, when
Mhm.
when you log in, they email you at the end of the week. So it's not something that you can go and access at any time.
they email you at the end of the week.
Yeah, so it's going to be behind. Like they won't.
Oh.
So they like I'm supposed to get an email like I guess on Thursday or Friday about I guess the head and neck stuff that you presented today,
Are they only releasing one at a time?
one at a time.
Oh, okay. So when I did it previously, I had access to all of them. I could do
It-
them in any order I want.
it's not.
So they're doing a single. So you're gonna get like the head and the neck later this week.
Probably on Friday. So I don't know if you can talk to anybody and let them know that there's an active class and maybe they can release everything so that we can go back and review it anytime. But I'm
Okay.
still waiting for an email from them. I can't access anything.
Okay, I'll reach out to them and see if they can populate all of them to kind of so that everybody can kind of follow along. I'll ask them. It doesn't hurt to ask. We'll see what they say.
Okay,
But yeah,
thank you.
it's okay. Yeah, no problem. I hope all you friends have a lovely night. If you work tomorrow, I hope it's great. If you don't work tomorrow, then I hope you have a beautiful night. All right. I'll
Well,
see you
thank you.
later.
Thank you for doing this. I
Okay,
appreciate
Thank
it.
you.
bye,
Of course. Y'all
Bye.
have a great
Bye.
night.
Mm-hmm.
everybody.
You too.